today we're discussing a condition that affects millions of Americans but often goes untreated. Many patients believe that numbness, burning, tingling, and foot pain are simply just something that they have to live with.
Diabetes, it is a rising epidemic. Medication management does play a role, but it plays a limited role. I feel tingling, I feel like there's little ants crawling on my feet, I feel like they're on fire. I would even just jump straight into something called a spinal cord stimulator. First phase is called a trial. It's kind of like test driving a car.
And I'm sure that means you have lots of success stories.
5 minutes after we turn on the machine, her hand literally just opened up. For the first time in years, she actually grabbed a pen and then she signed her name.
Hey everybody, welcome to another episode of the OBL and ASC Marketing Blueprint, where we help outpatient practices grow smarter patient education, better marketing, and conversations with leading physicians who are changing lives every single day. I'm Rachel Biesinger with Patient Pro Marketing, and today we're discussing a condition that affects millions of Americans but often goes untreated: painful diabetic neuropathy. Many patients believe that numbness, burning, tingling, and foot pain are simply just something that they have to live with or part of getting older. But advances in interventional pain management, including spinal cord stimulators, are giving people the quality of their life back. Joining me today is Dr. Chiu. He's an interventional pain physician at the Painless Center. He helps many patients find relief when medications are no longer enough. Thanks, Doc, so much for being here with me today.
And thank you, Rachel. Thank you for having me. And thank you for such a wonderful and informative introduction. So my name is Dr. Jason Chiu. I am a double board certified physician in anesthesiology, and I'm also fellowship trained and management board certified as well.
Tell us about how you got started. I really want to dig into a little bit like how you even started your practice, but what made you pick this particular field of medicine?
So I started off, I went to medical school in Texas, and at the time I was selecting different electives. First I thought about, hey, I want to be a plastic surgeon, but then, I worked in the OR and I realized, I see the guy who's sitting at the top of the table, reading a magazine, and I'm like, you know what, where I want to go into my career. So at the time I chose anesthesiology, and obviously, not because of that reason, but then, we started to learn about, different physiology, pathologies, et cetera, as an anesthesiologist, during my residency. And that's, I realized, during the later part of my medical school career, I realized, wow, this is a very exciting and very rewarding specialty. I have to know how to manage different pathologies, different conditions, from someone who's a neonate to someone who's, 99 years old or older. So it's a very, very interesting and challenging field. During my residency training as an anesthesiology resident, I was exposed to pain management. At a time, pain management was kind of a specialty that was really picking up. And what interests me was the amount of relief that people get, from these different modalities. And it's a very, very specialized field. And, as part of as an anesthesiologist, we're trained to do things like epidurals. The first day of our training, we're putting in epidural. We're doing different types of nerve blocks. We learn about pharmacology. We learn about, how to manage pain after surgeries or during surgery. So, being able to apply that knowledge into an outpatient base and being able to affect so many people that are afflicted with chronic pain conditions, that's part of the reason that really drove me into the field of pain management. And that's how I, went through the fellowship. I went through the board certifications, and now I'm able to practice that in my everyday practice.
Patient Pro Marketing, we help market for a lot of like MSK embolizations, and it's very pain focused, even on some of the uterine fibroids and things like that. Tell us, from running a specifically pain management, what types of chronic pain do you mostly treat?
We treat like a variety of conditions, obviously diabetic neuropathy, that's one of them. We also treat a lot of different, neuropathic pain, things like complex regional pain syndrome, which I'll go into later. We deal a lot with back pain, mainly a lot from, disc herniations. We do a lot of injury, people that unfortunately were injured. We treat a lot of those, acute pain conditions. We also treat things from, joint pain, shoulder, knees, hips. And we also treat, unfortunately, a lot of people, may have, things like fibromyalgia or, different types of, acute trauma, chronic pain conditions, or even cancer pain, unfortunately. So, yeah, so we do treat a variety of different conditions.
Yeah, it sounds like it's a lot. Why has specifically diabetic neuropathy become such an important area to focus for you?
I think diabetic neuropathy obviously deal with a lot of different types of neuropathic pain that has to deal with nerve sensitivity. So diabetes, it is a rising, epidemic. I'll say, in America, usual treatments for diabetic neuropathy has, solely rely on medication management. Obviously, the best management is to control your, blood sugar. That's obviously the number one thing to do, but unfortunately, that's not always the case. So medication management does play a role, but it plays a limited role, and at one point, then, that's where people start, having that knowledge, they start seeking for different specialties. What drives in pain management is the, ability to using advanced procedures to really treat this condition. Not a lot of different other specialties, have really explored or, been kind of, familiar with this type of treatments that we offer.
Yeah, I've worked with a lot of podiatrists in the past. How common is it though? Like if you say it's like growing, do we know like what the age range and what the percentage is for most people to experience diabetic neuropathy?
Then we have to look at, I guess, in general population, like what percentage will develop diabetes. I mean, that's, it is a pretty high percentage. I don't, and among those that develop that, about more than 50% of those, that, have a, let's say, hemoglobin A1C, which is a measure of the, in terms of your glycemic control, anywhere from like, above 7 or 8, more than 50 to 60% of those individuals can develop a painful diabetic neuropathy. So that's a pretty high population, especially, ones on, if your glycemic control is not, well within the limit. The way we define diabetic neuropathy is anywhere from, 6 months, of this condition. Then we classify that as, diabetic neuropathy, and then we tailor the treatment for that.
Okay, what are the classic symptoms? Like what would people feel if they had it?
We use different terms in pain management to describe it. Most likely you would have something, that classifies as neuropathic pain. So terms like, for example, allodynia. So allodynia is pain that happens when it doesn't shouldn't cause pain. For example, if I just, brush your foot, lightly, and then you're jumping up and down, well, that's allodynia because that shouldn't be painful. Terms like hyperalgesia, so things that are kind of painful becomes extremely exaggerated. So maybe I press a little bit on your foot and then you're, jumping off a chair. That's, something called hyperalgesia. Those are different types of terms that we look at, things that, that have such an exaggerated response to something that shouldn't be a painful stimuli. There's also dysesthesia, an uncomfortable feeling just with light touch, etc. Combine those are kind of clinical findings we typically see with diabetic neuropathy. Also decreased sensation, complaints of, oh, I feel, tingling. I feel like there's little ants crawling on my feet, all the time. So those are kind of, those are, when my feet are, I feel like they're on fire. So those are kind of like the typical presentations for this.
Do patients like feel that all the time or does it come and go? Like sometimes it tingles and hurts and then sometimes they're fine, or is it like once you feel this, it is constant?
In most severe cases, yes, it could be a constant feeling. Okay. Even at its the worst. So having that tingling and painful sensation is actually okay. What's worse is losing that entire sensation. Now it becomes like complete numbness. So that means your
Oh.
nerve, these fibers have been so degenerated to a point where, you're not even receiving these painful signals. So you kind of be blessed that, okay, you still feel some tingling, even though it's, but typically, yes, on a daily basis, you'll probably, most likely feel that. It does, get worse throughout the day, and it's very episodic, so it's not very constant. Usually it comes and goes, depending on the activities and, what you're doing, and obviously also depending on the severity of your, diabetic control. So.
It sounds terrible, honestly. I'm thinking about it now. And then the first symptom you're saying, just brushing or barely touching your foot. I can't imagine. I would imagine like even wearing socks would be painful. Like any sort of clothing or anything that a person would have to wear, right? Would also cause irritation.
Oh yeah, and that's really the number one concern is, oh, when I put my socks on, I feel the inside of my foot, burning, I feel this, throughout the day, as I walk a little bit further, I'm feeling more. So those are, you're right, those are, it's very debilitating, it's very, it's because you're on your feet all day. And this is one of the most important functions that we do is we walk and we ambulate. So
Yeah, I
it's
remember
definitely.
a story from
Mhm.
my podiatry days, and I'll just share this because this patient obviously had diabetic neuropathy where he couldn't feel anything in his bottom of his feet. And he came into the practice and he said, I keep hearing a clicking noise when I walk. The doctor's like, a clicking noise. Like, what do you mean? He thought maybe it was like his, sometimes your ankle or your joints pop, whatever. He's like, all right, well, walk for me. Let me see, what you're talking about. And he walked up and down the hall and he's like, well, I don't hear anything. And he's like, well, when you're at home, like, are you wearing shoes and stuff? Oh no, when I'm at home, I don't wear shoes and I have like hardwood or tile floor. So he takes off his shoes and he looks at the bottom of his feet and he's got a beer cap stuck in the bottom of his foot. So every
Oh,
time he would walk, he would hear that click of that metal on the ground.
one.
And the guy couldn't feel it, right? Because he had neuropathy. He was like, and he was
Yeah.
too big, I think, to see his feet like most patients. But I'll never forget that story on one, just how terrible that sounds. But the guy couldn't even feel his foot that he had a beer cap stuck in it.
How long did you have the beer cap in there?
I don't know. It's just,
Okay.
I don't,
It's just
I'm sure it ended up, being wound care and all this other stuff, but just going on like how severe the neuropathy can be that you lose sensation. Should a patient not ignore? Like some of it is okay, it's normal, but like when does it get to a point where it's probably severe enough that you should seek treatment from a provider?
definitely not to the point where, you have, a foreign object, stuck in there.
Yeah.
Yeah. And
Okay. There you go.
you're hearing noises. Obviously, if your hemoglobin A1C, it's in like the, 8 or 9 range, okay, then you have to kind of have that awareness that, hey, my blood sugar is not really well controlled. Like the classic symptoms, oh, when I get up from a sitting position and then, I'm walking and then now I feel this, tingling sensation that doesn't go away. Putting on socks or temperature changes kind of, make my feet, have this really bad tingling. I'm having a hard time walking. Those are also, so I would say at those points, then yes, you might want to like, kind of have a conversation with your primary care, physician to see, hey, am I, is this what I'm developing? Am I having this painful, especially if the symptoms last more than, I mean, the guideline is saying 6 months as official diagnosis, but honestly, if you're living with this, feeling this, even over like a week or two, I think you should really, start getting, get like some kind of like medical consultation.
Let's talk about the beginning of that process. So a patient's starting to feel the symptoms, they go to their primary care. What if traditional treatments for diabetic neuropathy been like? And then I'd love to jump into what you guys are offering there at the Painless Center.
So right now, the glycemic control, control blood sugar, but that it's not always the option. So then there currently are a couple FDA approved medication for diabetic neuropathy. One is called Lyrica. I'm pretty sure everybody's heard, some sort of, about Lyrica. It's called pregabalin. So it kind of, attenuates the signals, from these like painful stimuli. There's also Nucenta, which is also FDA approved, but it does have a little component of opioid in it. So it's not, it is a, very effective medication, but again, who wants to be on opioid for a kind of like nerve pain and chronically being on that. So also Cymbalta, again, that's another FDA approved medication for this type of pain. So those are all the major FDA approved medication to treat this. Interestingly, is there a long-term solution? Maybe not. About so we look at different type of studies, patients that have been on these medications, almost 90% of them actually kind of, either drop off from, using these medications or developing something that, long-term side effect, after 2 years. So it's
That
kind
was
of
gonna be
like,
my next
study
question
section.
is, a lot of those I mean, you see the commercials, they're all over the place, right? But they always have those side effects disclaimers.
Yeah, I'm not to say like, oh, these medications don't have the role. I prescribe a lot of these, Lyrica, gabapentin. I think they're excellent medications, but is it a sole, long term, modalities for these type of issues? I don't think it's the it's I don't think it's the only answer. I think it's a good supplement. If we can, introduce other modalities, then that would be, a more effective treatment.
Okay, so that actually gets us to what would be your treatment option then after that.
Interventional pain specialist, I provide different types of things, that I can help with this. Diabetic neuropathy, this is one of the only conditions, I want to say that, that I would even just jump straight into something called a spinal cord stimulator, or, other words like neuromodulations, because, I always tell patient like, okay, to the point where I'm putting in a spinal cord stimulator or I'm recommending it, that's what I call the Grand Cadillac of pain management. That means we try almost everything, and then now we're bringing out the Cadillac, coming out to provide this treatment because, I think, it's when you have failed a lot of different modalities. Somebody wants to come off a gate and say, hey, I want to have this thing implanted. I think it's kind of hard, but for diabetic neuropathy, that's actually one of the, FDA approved interventions that we can actually use to treat this condition.
I did not know that was FDA approved, so that's really good that you're sharing that. For those that don't know, can you kind of explain what the spinal cord stimulator is?
Spinal cord stimulators, or a more broad term called neuromodulation. The way this thing works, the way I explain to patients is, I ask them a question. Every time when you touch something that's hot, stump your toe or your finger into, in the door, like what's the first thing that you do? So typically the answer would be, okay, I would, take my finger, I'll maybe bite on it, or I apply a little bit of pressure. So you would think, well, how would applying pressure, help with pain? Well, interestingly, the sensation of feeling the pressure is, carried on by nerves that are different from the ones that carry the sensation of pain from our body parts. And it turns out the sensation that carries things like pressure, our proprioception, which is our perception of space, are actually fibers that are a lot bigger than the ones that carry the pain signals. And they actually travel a lot faster to our brain. So by stimulating these type of nerve fibers, we actually are in a race against the nerve signals from our pain fibers to the brain. So by beating those signals, that's how we actually provide pain relief, is by just, overstimulating a lot of these other sensations over the sensation of pain. And that's, we'll call it gate control theory. It came out about back in the 1970s, when neuromodulation first came out.
That's so interesting. So, how do you actually put it on a patient? How does a patient get this?
So the whole idea is to stimulate what we call a dorsal column of the spine. The spine. The dorsal column actually sits right below some call it an epidural space. Okay, so every time that someone's I'm pretty sure the listener may have experience with something called epidural. Where you're significant others giving birth. In the hospital. To come in and say, hey, I want an epidural. So that's when it happens. So we put a little same concept as the epidural during labor and delivery. We put a little device into the epidural space. Okay, so when we do the spinal cord stimulation, there's two phases. Okay, the first phase is called a trial. I always tell patient, it's kind of like test driving a car. Which is pretty awesome. It's one of the only procedures in medicine where you get to test drive it before you fully commit to it. Okay, so I say, okay, we put in this thing, these two little wires into your epidural space for about 5 to 7 days. Okay. You do things that you normally do. You like to jog and, go jog. You like to go do, competitive, whatever, sports, go do a little bit of those, and then see how different it feels, so the first step is we put in these two leads into the epidural space. That's typically done in the office, under local anesthesia. So we numb up the back. We use an X-ray machine to guide where I'm going. Okay, so I, with two little sticks, I place these little leads to the place that it needs to go. Okay, and then we turn on the stimulation through an external battery. Okay, and you carry that battery for maybe like 5 to 10, 7 days, where you do those activities. And then after the 7 days, you come back to the clinic and then you tell me, okay, for those, 5 to 7 days, how did you feel? Was your pain a lot better? did your neuropathy go down? Were you able to, walk a little bit further? Were you able to, put on your socks without, having those pain? Well, if the answer is yes, then I would say, well, then I would recommend we make this permanent. Okay. And permanent part, that's a second part, which involves me, making a two small surgical incisions. Okay. And then we actually implant this device into the back, and they'll sit on the epidural space. I would say, unless, you're very, self-conscious, about, going to the beach, or I don't know, that people, about people looking on your back, you're barely going to notice the two little incisions, that we use to implant this device.
Mhm.
So, it's kind of like, I would say, kind of like a pacemaker, where it is about the same size. You will see a little bit out the outline of that pacemaker in your back, but it's not something that would, jump out like, oh, wow, this person has a, spinal cord stimulator, so it's a pretty, pretty subtle device, in my opinion.
Yeah. You mentioned that the second phase is it's permanently placed. Does that mean this patient now has permanent pain relief?
So, look at different trials, so speaking of, going back to your, thing about FDA approval, okay? So there's only one device that's currently FDA approved, the stimulator device, which is, I don't know if I can mention the name of the company, but they stimulate at something called a 10,000 hertz of stimulation. So you need something that stimulates at that level of frequency to be effective. And so far, in my knowledge, there's one company that makes it. And that's the one that's currently FDA approved. Okay. The company is called Nevro. Okay, just throw it out there. So that's their device. Okay, so
Mhm.
they did a trial called Senza trial 2 years ago. Okay, and that's where they got the FDA approval. So most of the studies we're looking at, it's based on that trial. So for the 2 years, the amount of explant, that meaning that people had this implanted but wanting to take out is pretty much minimal. Is it a permanent relief? So far we're looking at a pretty long-term, pretty good outcome so far, based on most of our trials and what we're seeing. We usually look at that based on like, how many people want it to be taken out, but so far it's pretty much, minimal.
Yeah, I think that's great because I think when you go back to all the traditional treatment options, they seem very short term, minimal pain relief with side effects and things like that. That this sounds like a better alternative for longer term care or pain relief. And it's like you said, the studies are a couple of years old, right, for this particular product that's FDA approved, but they'll probably just get better over time, I would assume.
The Neuromodulation Society, they have a meeting every year, so they're constantly, evolving, they're constantly having, different investigations, different type of, studies. And the thing about, that this technology is that, just because once it's implanted, then it's a permanent, permanent setting. It's not. There are ones that you can control with your iPhone, when, someone can come and interrogate it, say, oh, okay, we're not stimulating enough of the feet, most of the stimulations in the knee. Well, let's titrate it. Let's move the setting a little bit. Let's stimulate, different leads. Let's get down to the feet. So it's something that, even though it's in your body, you do have the remote control and you have the ability to kind of play around with it. So it's pretty neat. I would definitely say this is one of the biggest breakthroughs in pain management in a while.
That's awesome. I did not realize that it was all ran from your phone too, that you could do
Yeah,
that.
it could be. Yeah, yeah.
So once you implant the device, and I know you said you have that like 7 to 10 day trial, do people usually like wake up, leave, and feel good? Or does it take time for the process to work?
A lot of people I see, just from anecdotally, about like 2 to 3 days, they would feel, they would already know. Some I even have patients, after 2 days, they come back and say, I'm done with this trial. I just want to implant it. Like, I know I want this. And I'm like, okay, go for it. Something even more interesting is, I actually have patients that went through withdrawal after the implant because, so I have patients that were on opioids and they feel like, wow, this is so amazing. My pain is really, such a big improvement. I don't need to take these, Percocet or oxycodone. I'm just going to stop taking it. And next thing you know, they're not having pain, they're having withdrawal symptoms. So that's sometimes how effective, these modalities could be, to the point where, kind of wing off on these medications, so quickly that, I do have a case where they actually went to withdraw from being able to do that.
If patients have questions about this, right? Like, what are the main common patient concerns? Like, does it hurt? You mentioned the pacemaker thing. Sometimes you can't like have MRIs or go through metal detectors with certain things once it's implanted. Can you go through, Dr. Chu, some of the concerns that patients have and maybe how you address those?
So like any device, patients' main concern is, oh, we might turn into like like a bionics or, like robotic, and I get it, it's, it is an implant, it is something but, like I say, it's a pretty small device, the lead, they're, in the size of like millimeters, which is just a, little bit bigger, than a couple strands of hair, that's going to be implanted to your back. The battery that's implanted, it's actually getting smaller and smaller now. So it's definitely came a long way. So let's say, do people think twice before to have to get a pacemaker? Well, maybe not. Same thing with this. It is the pacemaker for your spine. Would you rather be in chronic pain? Being or would you rather just have this device put in and feel the relief that you had during the trial? So that's a lot of people's concerns. In terms of metal detectors or MRI, so most of these technology now they are MRI compatible. Okay, meaning that you could get an MRI even with this device in place. Metal detectors, again, that all depends on different models. But if you do have carry some type of identification cards with you, to the airport, then yes, that would excuse you from, obviously, any, all depends on sensitivity of the detectors, etc. But yes, that, it hasn't really been an issue, going through metal detectors, etc. Those are kind of main concern. Aesthetics, people think, oh, am I, I have a little pocket. It is a small little pocket in the back. Okay. Again, like I said, if you're not if you're, if you don't, your life career is not dependent on like, swimsuit modeling. Okay. I don't think that would be like a major problem.
Yeah. I mean, it sounds like
So
you could do all your
uh,
normal life activities. You talked about like working out. You could still work out with it. You can travel with it. It's not really anything that's gonna hinder your normal activities. It's gonna hopefully make them more enjoyable, right? Because now you're not in pain.
yeah, correct. That's the whole goal of this thing, is to make you
Yeah.
go out there to be active. On the note of being, doing, physical strenuous exercise, and I do have to point out, there are cases of something called lead migration. Okay, meaning that we put this in, someone gets so excited, before it, so our body takes time to form something called, scar tissues or, to granulate, around these device. Okay. So then that way it's permanently anchored, as part of your body kind of. So it does take time for that to happen. There it's a period where we do not recommend that you go out there and, do something that's too strenuous because that could migrate that lead. If you think of, if you know that these leads are placed very meticulously, even just, a couple millimeter difference or etc., could, change that entire setting. As excited as people may initially feel when they first have this in, still we say, okay, you got to kind of hold off on that for a bit until, the body takes its time to work around these, new device, and then now you can go, activities. But yes, it's such a small price to pay, for such a big like change in the quality of life.
Yeah. And you had mentioned earlier if you don't like it or if it's not working, you can remove the implant.
Yeah, so we can surgically take it out, correct? Yeah.
Yeah. Do you even know how many of these you've put in patients? Do you have any idea?
So even it's like in fellowship, sometime, so for now I'm in practice about like, 10, 12 years. Sometimes I average about, I do trials, sometimes I average about two, a month, sometimes three, four. So I just do the math, I think, yeah, it's quite a bit up there.
You have
Yeah.
substantial experience putting these in. And I'm sure that means you have lots of success stories. Do you have maybe one or two that you can share with us, like a patient that stands out that you'll never forget his or her reaction or whatever, how this changed their life? So if somebody is kind of thinking about it but concerned, like I feel like hearing patient stories helps people make a decision?
Every one of them to me is a success story. It's just, but even just improving the quality of life for like 10%, oh, I couldn't pick up my grandson and now I could, bend down and, I can play with, my grandchild, that's to me, that is a pretty big success story. But one of them, really stuck out with me the most was when I first started, my job at a hospital. So I'll say, I was fortunate to be the pain director for a major hospital. And at that time, neuromodulation just kind of started picking up. So I had this lady who unfortunately had, she was involved in a car accident and she had some burn injuries to her hand, to her thumb, to a couple of her fingers. So her hand was just chronically contracted, like pretty much this is what she had to deal with. Very painful, even with light brush, so the allodynia thing was definitely there, light brush, she would, have this jerking movement, almost like tearing up just with light brush, temperature changes. And, I did a couple of nerve blocks, something called stellate ganglion block, for this. So she got some, temporary relief. And at that time, I was like, hey, let's do this thing called a spinal cord stimulator. The always, looked at me like, what is this guy talking about? He just came out of fellowship. Like, is that what they learn in training? Like, what kind of putting a lead in my neck? Like, what, what in the world? But she was running out of options and she said, you know what, let's try this. So we did a trial, it's a cervical lead where we place a lead, somewhere around the neck, into a cervical spine. 5 minutes after we turn on the machine, for the trial, her hand literally just opened up. And then, for the first time in like years, she actually grabbed a pen and then she signed her name, one of the documents that, from the hospital. And yeah, she started crying. And then, even that kind of like made me want to like, I kind of almost like, I had tear in my eyes too. And it was phenomenal. Like she was right-handed. And then for the first time in so many years, like she actually held up a pen and she had that coordination ability to sign her name on a piece of paper. So that sold me on that neuromodulation. Yeah.
That's an amazing story. I got teary-eyed from that. We think about things we take for granted every day, right? Like holding a pen. That doesn't sound like a
Exactly.
big deal,
Yeah.
but then from
Mhm.
someone who's been in something traumatic as a car accident and has these permanent burn, scarring, and ailments and all the disabilities now, and just to be able to watch her take her hand within 5 minutes. That's an
Yeah.
amazing story.
Yeah, it's phenomenal. Watching that, it's like, wow, like nothing, it's like makes like all the training like, worthwhile. So
Yeah. Yeah.
yeah.
You're like, "You get a spinal cord stimulator. You get a spinal cord stimulator."
Yeah. Yeah. That's all. Like you
Everyone
look like
gets
you
spinal
got
cord
diabetes.
stimulators.
Technically, I think you could. There's so many indications for that thing. It's amazing. It's yeah, but even for like chest pain, for yeah, even for like pains from like coronary arteries, or chronic, angina, things like that. There are people like putting in, spinal cord stimulators for that.
Wow. So it sounds like there's
Whoops.
so much. I mean, we started just
Mhm.
with using this treatment for diabetic neuropathy, but then you're talking about the lady with the hand. You could use it for a lot of different things.
You could use, I think it's, it's just love your imagination. And I think it's so grand. It's in, like I said, test driving a car, I would say more than half of, 30% of medicine is trial and error. I'm never going to know this is going to work 100%, but with the ability to try it first, you can really bring that percentage, a lot higher. I didn't think this was going to work for her. I was like, look, I don't know what are the options we have. Why don't we try this thing? And that's exactly what it is, a trial.
Yeah.
And I did it, she loved it, and then we implanted, and that's the rest is history. So I think it's really cool. Not a lot of things you can like try out before you really commit to it.
So, if somebody is suffering with diabetic neuropathy, what are some of the, I mean, you said the first step, obviously, right, is go to your primary care doctor. What do you wish those patients knew? Because do primary care doctors know about spinal cord stimulators, or like how do they become aware of this procedure?
So
That's kind of
usually the
a question.
ones,
Sorry.
yeah, yeah, I mean that's like I mean definitely that's a very good concerns. Most of them I get are kind of primary care physician may have started them on those medications, the ones I mentioned before, and to a point where it's like, wow, you're still in pain. well, you know what? Then let's send to a pain management specialist. So they're not being sent to me with a specific mindset of, okay, let's try some, neuromodulations, with the spinal cord stimulator. Most of it's like, okay, we don't really know, we kind
Okay.
of maxed out on these Lyrica or whatever, for the last 2 years, what else can we, let's go, go see a pain specialist. So that's where I get pretty big chunk of these referrals from.
Okay, that makes sense. So they're sending them to
Mhm.
you to manage pain moving forward because what they are
Yeah.
limited with isn't enough.
Yeah. Not with a specific treatment in mind, but just say, like, what can you do about this?
Yeah.
So,
And we recently started some direct to patient marketing for you for diabetic neuropathy, which I think kind of goes hand in hand with some of the other MSK stuff we do for interventional radiology is we, create these ads targeting or asking patients who have tried all these medications, injections, whatever, it's still not working. Has that worked out for you? I mean, honestly, we haven't even had a conversation about
yeah,
both sides.
I think it is, definitely seeing like a, pretty, I haven't written the numbers in terms of, but yeah, but compared to before, yes, we're definitely seeing more and more like direct referrals.
Yeah.
People come in specifically for those concerns. Like, I have like burning, feelings in my feet. They may not all be like because of diabetic neuropathy. A lot of these can be vascular issues. So a lot of these I do end up doing a vein scan. I want because a lot of times could be a vascular, but it could be vascular insufficiency. Could be some
Yeah.
type of a lot of these could be from a herniated disc. If you have a nerve compression, you are going to feel some tingling sensation shooting down the foot, the feet. A lot of these I end up seeing them to do an EMG do a nerve study. But overall, yes, the campaign, I think, we're definitely seeing like a pretty, a difference from before. And I'm kind of glad because, a lot of people, these people, they didn't know about these treatments and they kind of just been living with it. And,
Yeah, I
they,
like to think that digital marketing is more like digital education and awareness, so it's something you offer. You've been doing it for a long time. You have a lot of experience, but how do you let people outside of your primary care circles and stuff know? So I mean, I'm glad to hear it's working, whether it's the actual diabetic neuropathy patient or not. To me, that just shows that people are looking for options, right? That they're looking for help and looking for relief.
I think you built like a, very nice like platform where, as long as I see ads, I see my own, I don't know why, but I see a lot of, I get a lot of hemorrhoid, ads from my own practice. Maybe because I click on it and then now but like,
Yeah, I think you
you
might
know,
know a doc that can help you out with that.
yeah.
Let's talk about your practice
uh,
because, I don't get to sit down with just like interventional pain
uh,
physicians very much. Is there anything exciting, that you're looking forward to in the industry or like new procedures and things that you guys are looking at offering?
Obviously, with my partner, my partner, Dr. Kumar, I think this combination of, what we set up, we have something very unique. Not a lot of places would be able to offer that. And also having the expertise, me, humbly in the pain management field, I think I'm, definitely have the background and the training, certifications to be able to provide those services. So it's Dr. Kumar, I think, goes without saying. I mean, this guy is like internationally known for what he does. So, with this combo, I think, we really have something that's like very unique in terms of just on my side, because I know he's going to do his own, whatever podcast or, I mean, I know the guy for like 20 something years. So I know he's going to, he has a lot to talk about. But, from my side, pain management is very exciting. Interventional pain management is a very exciting world because, it's always evolving. And the way I like to look at it is, maybe 30 years ago, 30 years ago, the specialty, again, I'm not trying to compare, myself at that level of, the training and expertise, but, the field of something called, interventional cardiology came out. Okay. Where, for example, before doing a bypass procedure for a coronary artery disease requires, opening the chest, taking out the blood clot in the coronary arteries, putting in a graft, etc. Obviously there is still a place for that, for the more severe disease. But when interventional cardiology came out, they could literally bypass that blood clot, using catheterization. So cardiologists were doing these minimal invasive procedures, to release something otherwise that might require a major, thoracotomy, etc. I think pain management can evolve into that, and it is evolving to that place where a lot of these spine procedures can be done minimally invasively, using small incisions, using kind of like, percutaneous approach, things like percutaneous discectomies, percutaneous endoscopic discectomies, minimally invasive lumbar decompression. So those are just to name a few that, that pain management physicians are, the ones are, trained, to do these are kind of getting, more and more and more popularities in terms of those procedures. We'll never replace what, neurospine surgeons can do or what those spine surgeons can do. I'm never going to say, but, with some maybe more minor pathologies, et cetera, that can be done minimal invasively. I think there is a role for pain management. And I think that's kind of where the direction of most of the trainings, for, fellowship trainings, et cetera, for pain management is going to head to. It's going, I think that would be the new direction, in the next couple of years.
Yeah, I do think your collaboration with Dr. Kumar as an interventional vascular interventional radiologist, I think it's amazing. I think what you guys have built there is super smart because you look at the whole patient, right? And they may start with something more minimally invasive, right? On the pain management side before they need like an embolization or something else that Dr. Kumar might offer, or vice versa. I think you guys could probably really handle patients like from A to Z.
When you first approached me with this idea, maybe like 2 years ago, and I'm like, wow, I'm like, I don't know, I'm like, I'll be, you're a smart guy, but I don't think this will ever work, like what do you mean by embolizing a knee? Like, well, like I want to just, put steroids in it or whatever, But I never thought, from that point where we could like collaborate,
Yeah.
to the point where we, could really offer, so many like, different ways that we can help pretty much everyone. These things are a common disease, that everybody has. Like who doesn't have knee pain, who doesn't have, BPH, or who doesn't have diabetic neuropathy, who doesn't have joint pain, who doesn't have, it's such a common modalities for such common illness that everybody has, so I think it's pretty amazing that we're able to capture like all these,
Yeah.
and
I think it's a
really
great
providing
concept.
the service. Mhm.
So before we close out, Dr. Chu, can you tell everybody where they can find you? You've got multiple locations, maybe mention your website.
Sure. So the practice, it's called the Painless Center. You can't forget that, it's very, it's pretty straightforward, the
Uh,
Painless Center, which we paint. The website is again, www.thepainlesscenter.com. So we're very active on Instagram and also Facebook. My Instagram is the Painless Doc, you can easily, find that. We have location in Inglewood or Tenafly, New Jersey, and then also Clifton, New Jersey. Those are our main two locations. We also have satellite places, but if you call our office 201 592 7246. Again, it's 201 592 7246. So it's 7246 spells out to be pain, so that's not
that's
201
cute.
592 pain. So we call a number, can always schedule a location that's the most convenient for you.
I love it. Okay. Well, I will make sure we turn that into a jingle for you at the end here because I think that's pretty cool. Is there anything else you want to share before we leave for anyone who might need some extra words of advice from you?
I think a lot of these audience or might be other, healthcare providers, I think, my advice is, do what you think it's right, do what you think is right. When you believe in something, just go for it. Okay. There will be obstacles and bumps along the way. There's nothing that's easy in medicine. I think we all know that. But if you, stick your mind to it, you do what you believe is right, what you think, really, is a pristine service. You are very well trained. You do have, you have a very, very strong background in knowing what you're doing. If you stick to it, people will come to you, and you'll make a difference in, people's lives.
Awesome. Well said. All right. Well, thank you so much, Dr. Chu, for being here with me today.